Hello, hello. Welcome everybody to another edition of Chris's Corner, the Wednesday before Thanksgiving. So I'm super excited about this. Definitely make sure you announce where you're from. We always like to hear where our community is checking in from. So kind of mention whatever state, whatever country you're from. We always love to hear that. And also say hi. Announce yourself in the chat. We would love to hear from you. So today we have a very exciting episode. So we're going to focus on a lot of different topics today, actually. So we're going to focus, it's Men's Mental Health Month as we wrap it up of November. And so I brought on two gentlemen that I think can speak to just how men are impacted in the OCD community. And we're going to have a really good discussion with Chris Baer, who's a father who I'll announce in a second, just about the role fathers can play in treatment for their loved ones. It's also the Wednesday right before Thanksgiving. And if you're anything like me, holidays brought on so much added stress, anxiety, which impacted OCD. So I definitely want to make sure we chat about that a little bit. And then I have two great guests on that have lived experience and clinical experience. So I'd love to hear from you just general OCD questions as well that we can answer. So whatever platform you're on, we're streaming live to a bunch of different platforms, including YouTube, here on Facebook. We also have LinkedIn and some others. So make sure you announce yourself, say hi, and definitely ask any questions that we could answer. We'd love to support you right before this holiday season here at the IOCDF on an episode of Chris's Corner. So just to let you know who I am, my name is Chris Trondsen. I'm a clinician that treats OCD and related disorders in Orange County, California, and I also have OCD. So before I announce my very special guest that I'm excited to have on, I just wanted to always do a quick reminder that this live stream is intended to serve as educational content and is not intended to replace therapy. So for treatment-related questions, please be sure to work with your local provider or contact a local clinician. The International OCD Foundation is not a crisis hotline and should not be used if you are in distress or feel unsafe. If you are in a crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255. We also want to create as safe of a space as possible and be kind and respect everyone. With that, this is being broadcast on various social media platforms and is being recorded. So please be mindful of that as you ask personal questions or leave comments. At the end of the day, we are all here to support each other. All right, as always, Chris's Corner is not anything without its guests. So I'm really excited for my two guests today. So my first guest is Nathaniel Van Kirk, PhD, and he is a licensed clinical psychologist, specializing in severe anxiety disorders, OCD, and trauma and PTSD. At McLean Hospital, Dr. Van Kirk is the director of inpatient group therapy and the coordinator of clinical assessment at the OCD Institute. He is a member of the hospital's Patient and Family Advisory Committee and Interdisciplinary Recovery-Oriented Practice Committee, and also serves as the site facilitator for McLean Schwartz Rounds Committee. So Nathaniel, thank you so much for coming out.
My pleasure. Thanks for having me, Chris.
Do you like Nathaniel? Do you like Dr. Van Kirk?
Nathaniel's perfect.
Okay, makes us feel like we're best friends. We go way back. I like that. And then my other good friend, guest is Chris Baer, who is a parent of a teenager with OCD living in Brooklyn. By the way, it's always crazy to say teenager. I'm sure it's even more crazy for you, Chris, because I feel like I've known your daughter since she was little. So he understands the struggles parents and young kids go through on a daily basis dealing with this disorder. Over the past few years, he's used his affiliation with producing Unstuck, an OCD kids movie, which is excellent. If you haven't seen it, please go check it out. It's to advocate for those with OCD and their families around the world. Chris has spoken at mental health conferences, created OCD Deconstruct, a global digital OCD conference, and hosted OCD Kids Speak Out, a monthly live stream show. So welcome to the show, gentlemen. I'm so happy to have you on.
Thanks for having me. Hello, everyone out in the cyber world.
Absolutely. We already got some highs. It's always good to see Phyllis, a good friend. So please, like I said, make sure you announce yourself in the chat and let us know any questions you have for my amazing guests. So we're going to talk, like I said, about a couple different topics. It's Men's Mental Health Month that's wrapping up, so we definitely want to touch on that. And then also, it's right before the holidays, which can add extra stress, and then just some general OCD questions. So I want to start with you, Nathaniel. So with men's mental health, I mean, one of the things that the statistic shows is just, for men, it's a lot harder to get them into therapy, or it's a lot harder to open up and to reach out to support groups or to their family system. So working with OCD, and in your male clients, what are some of the unique challenges that you see that sometimes they have to overcome if they want to be successful in OCD therapy?
I mean, I think it's a great question. I think with the idea too of how do we just in general get people into treatment, and make it something that's okay to talk about. I think that's one of the biggest challenges is sometimes the stigma around mental health and just emotions in general, and how, like, who do you go to? Who do you talk to? Is it okay? How is it okay to express your emotions? How to, in some cases, how to do that effectively or feel comfortable with it. I think those can all be challenges, and especially exacerbated around the holidays where emotions at times can run high when everyone's stressed out at times too. But I think just education in terms of, that mental health challenges is a human experience. We're all human. We're all going to have things that we face at some point in time, and they're all going to affect each of us a little bit differently. Although there may be commonalities. And so I think a lot of it comes down to just the education and outreach, and also just normalizing the conversation itself. And I think that's also one of the big challenges when it comes to treatment is, how to find supports. If you feel like you have to keep everything to yourself, who do you go to? How do you find supports? How do you communicate what's going on with your loved ones, with those that are there to support you? And I think that no matter who you are, can be a challenging thing with OCD. A lot of times too is taking that first step to actually say, like, I'm struggling with this, if you don't know like what you're struggling with. Similarly, I have lived experience of OCD, and that the first couple months of those intrusive thoughts where you're like, I'm not really sure what's happening, but I'm not supposed to be feeling afraid all the time or feeling anxious all the time. Like, it's not something that I'm supposed to share. I think that can be a really daunting and challenging moment, and so the idea of normalizing that discussion can be really helpful.
Why do you think it's so much more challenging to get into mental health treatment, specifically OCD? Because, if somebody gets diagnosed, let's say with cancer, or let's say somebody gets diagnosed with, a heart issue, most people don't have stigma around it. And in fact, when they go into that kind of treatment, their family support, shows up and people are helpful. Why do you think it's unique for the OCD community, especially maybe if you have taboo thoughts? Why do you think it's so hard for people to be willing to open up, to find help, and to admit that they're going through something to family and loved ones?
I think a big part of that is the education and misinformation sometimes around OCD, but also just I think when people are first starting to think about mental health treatment in general, right? There's kind of this expectation that people have, whether they kind of express it or not, sometimes about what it means to struggle with mental health, especially if you're struggling with intrusive thoughts or violent thoughts or taboo intrusive obsessions. In those instances, there's this idea a lot of times that makes them more powerful, that others don't struggle with this because no one talks about it. But we know from the data and lots of studies that there's no real difference in the content between intrusive thoughts for those with OCD or those without OCD. We all have aberrant thoughts that pop into our head, but I think it's that idea that somehow this thought means something, so I can't share it in case it's true, or in case it does mean something specific. What are others going to think? So I have to keep this to myself as long as possible and figure it out on my own.
Absolutely. I agree with that statement. I know too, the education out there on OCD is so heavily focused on contamination and checking. And my hypothesis as somebody with OCD and an advocate, it's so much easier to go on a show or do an article or open up on Facebook about having, an experience where you couldn't leave the airport because you thought you left something behind. But it's really difficult to open up and talk about having violent thoughts against children or sexual thoughts about your family members. So I think when we can normalize the conversation around taboo thoughts, we're going to see so many more people diagnosed and accepting that they have this disorder, because it is so misunderstood generally.
Yeah, I think the education, it's important to kind of talk about the idea the education goes both ways, both for the general public, but also for providers. One of the unfortunate statistics is that around 38% of individuals with OCD are misdiagnosed. And a lot of times those do come from those intrusive, taboo, unwanted, thoughts and obsessions. And so I think we also have to educate our providers as well, and primary care providers, of what's actually happening, and so that they can help normalize that conversation. And so I think that's another important piece of getting people into mental health, is making sure that we're actually reaching our colleagues and educating them on what OCD actually is.
Yeah, actually, in the latest edition of the IOCDF newsletter, if you go to pages 5 through 7, I took my thesis and wrote a whole article on everything you just talked about, why people aren't getting treatment and diagnosed properly, and the statistics of how many general health practitioners misdiagnose individuals with OCD is staggering. And I want to bring you in, Chris. Like, what helped you navigate to an OCD diagnosis? So obviously, we know your daughter has OCD, and you guys have been such a force in sharing the story and getting people to understand the family component. Just like Nathaniel was just discussing, how did you navigate, and did you come up with barriers where you got misdiagnosis or poor clinicians before finding the right care?
Our story is very different, I think, and I wish more people like had what we say was more lucky, that our initial therapist that we went to were like an art therapist, and the art therapist quickly informed us, like, I'm not the right person for you. And that helped us because it saved us time to waste 6 or 8 months trying to figure this out if it was the right thing. Our personal family journey too, to jump into therapy and to believe this was like, to what Nathaniel was talking about, like OCD is going to be, mental health and therapy is good for you. It's helpful. Like, I've been in therapy twice for, my own issues, my wife as well. So we saw the value in therapy. So some of the barriers that others may face or feel, the stigma, like I can identify with what Nathaniel was talking about there. Both times I was in therapy, it was this, like, I can remember moments where I was like, should I say something to somebody that I'm actually doing this, and there is whether it's you're saying to a best friend or a small family, but I definitely had a point in my life where I was like, I don't want to tell the people I work with that I'm going to therapy because of things that are happening at work. But back to our OCD story, so it was a combination of, we found a therapist very quickly, and we knew that, like, our daughter had asked for help. So it was like our job as parents to get that help. And then, getting her into a program, but also like doing our own research and just like anywhere and everywhere, trying to piece together as much information as possible, buying books, reading them. My wife and I would kind of like compare notes every night. Like, what did you find out? What did I find out? And that's how we learned about ERP. That's how we learned about, like, asking questions about what type of therapy, when you call the therapist, what do you do? Do you understand ERP? Do you know what it is? Exposure and response prevention therapy. So it was a combination of making sure we found, therapy quickly, but understood like what we really needed. And so it was a lot of like legwork on our own and trying to understand OCD in a very limited way in a few weeks. But we were lucky and able to find an OCD therapist and get Vanessa into treatment like within 12 weeks. I would say that the symptoms first happened, and then maybe 4 or 5 weeks after diagnosis. So it was really quick, but it took a lot of time and effort. It became like a second job for a long time, to just, through a summer of just making sure we have the right resources for her.
And Chris, the reason I'm really excited to have you on, when Liz and I were talking about this episode, because we kind of collaborate on ideas, the reason we wanted to bring you on is one thing that Liz and I see in our practice is often the moms are, play a role and the fathers play a role. And it doesn't always look like this, but traditionally, we see that the moms will tend to be the ones that accommodate and are answering all the questions and doing compulsions for their loved one. And then on the opposite end, the fathers sometimes may feel like they need to overcompensate. So they're the ones getting mad or angry or loud, or why won't they just stop? Or I'm so frustrated. And obviously that's not everybody's story. And we hope it's not everyone's story, but that seems to be traditionally. So as a father, how did you go into this journey, understanding Vanessa, understanding her struggle? And, obviously I wasn't there through the whole process, but from everything, seeing the outside of your story, it seems like you did a lot right. So what was it that you could maybe pass on to fathers or parents in general, or guardians in general, that you started to learn about how to support a loved one with OCD and not falling into those traps we sometimes see fathers fall in?
I think a lot, to your point, had to deal with my mindset and understanding, and having a belief that therapy can have positive outcomes, and it did for me. So knowing that, but also having this idea that like it's okay for somebody to have that, and putting my daughter's health before anybody else. Before stigma, before what what others might say or think. It was and my wife as well, understanding that, she was my partner in this, and somebody that I could talk to and confide in, and we could kind of have our disagreements and talk about how things work, and how it would work, and what we believed and what we didn't. And then taking, I think it does take a big leap to say, what's the process and do I trust it? And then understanding, like, okay, like you read a book, what to do when your kid has OCD, or, some of the books that are highly recommended, reading other people's stories and going, okay, maybe this doesn't relate 100% to what Vanessa is describing as her issues, or my child is describing as their issues, but let me trust this process. And then, coming to a realization that, maybe what the books say, it might not be your exact story too. If they say, well, this took 6 months, understanding that maybe yours will be short, maybe yours will be longer. But I don't know. For me, it was about, like, let's our daughter is coming up with this issue, and she's really showing her need for help, and let's treat it seriously, and let's get her the help she needs, and then, adjust from there. I implore people to do their research, understand that, like, the way you grew up and the things that you were told when you were younger, or things you observed in society, have changed and are different. And sometimes that can be a good thing to try something different, or try something that might be a little more uncomfortable to you personally.
Absolutely. And I think what I heard from both you and Nathaniel is just destigmatizing therapy in general. I think that's such a big thing, because we don't stigmatize medical help. Nobody's like, oh, you're going to go to the doctors because you broke your arm, weirdo. But for some reason, it's like therapy if you go to get help. Nathaniel, I didn't know that you had lived OCD experience. It's great to find out. You learn new things every day. Maybe for you, like, what opened up therapy to you? What made it okay for you to go? And what are things that you feel like loved ones or supporters, or even individuals with, can kind of do to reframe the idea of getting help?
I think that, during so I went through treatment during high school to start, and I definitely say that I had all sorts of excuses for what I was doing or why I kept missing school. In hindsight, none of them were super convincing or super good, but it was kind of like the best I could come up with at the time. But I think that was part of that idea, is like, what happens if I let people at school know? And what was interesting is, over the years, what I found is that if I let people know, that generally most of my friends were supportive. They were curious more than critical. And I think that took a long time for me to learn as an individual. And it was kind of something I had to come to, like, kind of in my own. I always remember one of my best friends is, to this day, swears they never knew, but while I washed my hands for hours at a time, was sitting downstairs just emptying the ice cream out of our freezer, like, routinely, but would just stay when I was able to get out and kind of move on. He's like, all right, ready to go? Let's go. And like, there was still a disconnect, I think, as a high schooler too, between, oh, they're supportive, and so it would be okay to share that I'm struggling, because they notice anyway. And so I think it's also giving other people sometimes credit. Sometimes it doesn't go great, but also sometimes you get really surprised by the people around you. And it took a while to learn that, but I think, just that support and encouragement from those around you who are just willing to be there with you as you go through it, and be supportive, even if they're not saying much, but just being there was really important, I think, for me to kind of really engage in treatment as I went through it. And then finding a reason. I always talk about this thing clinically, this idea of, like, what is the reason to take the risk that your obsession is true? Like, what would make it worth it?
Absolutely. The why is so important.
Yeah. And Chris, I really liked what you said, with the idea that when you read other stories, that it may not map on. I think that's also one of the big challenges with thinking about mental health treatment and recovery, is the idea that, well, there needs to be, like, this end goal. I can only do this if there's a specific end goal. I know exactly what it's going to look like. Yet we know from all of the mental health kind of data in the recovery-oriented practice literature that change is non-linear. It's kind of like the stock market. It goes up and down, loops around, it's an ongoing process of learning, because these are also, in many sense, like, exposure is a great life skill. You can face the worst that your mind can throw at you. You can face pretty much anything in the world. That's a great skill to learn and utilize, but it's that ongoing process. So it'll look different for each person. I think that's incredibly important. So I'm really happy you shared that.
Yeah, I think about like a lot of times you would describe Vanessa's, battle with what she was, her obsessions, her compulsions, what she feared was like 2 steps forward, 8 steps back a lot of times, or, the roller coaster analogy, or just like a heart rate chart where it's just boop, 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 up and down. But there was certainly a time when it went, when there was a lot of jumping back and forth, and then it was just like all like a giant, vertical straight to like, over a few weeks time, eventually like getting over so many of her big fears at once. And it was just, the repetition of doing the ERP, doing our homework, going to therapy, positive reinforcement, doing things that, we knew that we, believing that the therapy would work. I saw there was a question from, I think it's Felice, about anger.
Yeah,
and
if we could bring that question up, Chelsea.
I definitely can identify with that. I think when something was so disruptive in our house that there, you couldn't help but go like, really, we really have to deal with this now. If I think back to when Vanessa was really going through her issues and we didn't know what the heck it was, like, I think this was like 2012, 2013. I had just started a new job a few months ago. So it was like, I have to show up at work. Both my wife and I were trying to, handle young kids as well as like, trying to grow our careers. So there was like, really, we have to deal with this. Great. Now I have to make a call to insurance and figure out like, what are our mental health coverages, and find a conference room to sneak into to interview people. Like, so there was that annoyance and like, absolutely the feeling of like, well, my kid is different and why is this my kid? And, how is this going to affect her? And that all the, brought up some frustrations. And so I, while that wasn't the emotion that stuck with me, I do understand it. And I wish there was ways that, you could get through to somebody personally. I think, I know that, when one of the parents is dealing with the brunt of everything more than the other, it certainly makes it harder. And my wife and I just found that like communicating as a team was, what helped us. And when she had a question or was curious or didn't agree with something, we would talk it out. And sometimes, when we had to decide on the actual making the step to medication, I became an interrogator. I really was very hesitant about medication and what it would do to a young child. And so there was a lot of conversation there, and I wouldn't say anger, but there was a lot of hesitancy that I had to get over and eventually, agree to. But, I can identify with a lot of the frustrations you normally feel. And there's also just that, like, my kid is not what it's just something frustrating that the kid has to deal with. You have to deal with a disruption in the family. How is this going to affect me? So many different emotions that you have to get over. So, I don't know if that's any helpful answers, but I know that, it's common to go through it.
Yeah, Felice, thank you for that question. And I want to ask you about it in a second, Nathaniel. I know, Liz hosted an episode with my mom, my sister, and I, and we really opened up about anger. And I know for me, especially during high school, when it was at my worst, I didn't know what I was going through. And so there was a lot of breaking things, a lot of slamming doors, a lot of like physical intimidation to get things going. And like Felice is saying, is that she's seeing a lot of anger from her husband right now. Nathaniel, in your clients, maybe even in your own experience, what is it that you believe brings on this anger? Because that's one of the biggest questions I get in my practice is parents will say, like, I don't even recognize my kids, or I don't even recognize my husband. This isn't the man I married, or my mom is now angry every time we come over and we move one thing and she yells at us. We don't even want to see her. So maybe explaining to people that don't have OCD or individuals with why anger is such an emotion that we see in this disorder.
Yeah, I think it's a great question, and it's an important one, because anger, I think across the board, one of the things that we see is, and the way I like to frame it for people is when you feel like your life is out of control and everything's uncertain and you're afraid and terrified, anger feels better. in a lot of cases for individuals. Because it's essentially, it kind of fakes control. That if I'm angry, I feel like I'm doing something, or that I'm attempting to control something, versus admitting that I have no clue what's happening or what to do, or I'm not sure if I can do it. I think what we also see in younger kids as well is that like things like anxiety and depression tend to come out as frustration and anger, because it's what they're a little bit more comfortable displaying, but also kind of developmentally is a little bit easier at times to articulate. And I think that also happens in adults, right? When we get really overwhelmed, a lot of times people we always get the example of like when you're really, really frustrated with something, and then you just kind of like throw your phone at the couch. And like, as you're doing it, you kind of know like, I shouldn't do this, hold it back. Like that's actually that's a computer. This probably isn't good for it. But in that moment, that feeling of just like wanting to let something out, to feel a sense of control a lot of times. And I think in some ways it can feel protective. But it's a short-term kind of protective that tends to get in the way of long-term gains. But it's also one of those things that usually isn't necessarily directed at when it comes to like OCD, isn't really directed. It's directed at someone, but a lot of times it's not usually about that person. It's about like the fear, the anxiety, the frustration of the situation, or for the individual. I know for me, it was about feeling out of control. Like I knew that I was doing the stuff that I just like was hurting others around me. Why am I doing it? And frustration of feeling out of control in kind of my own life, that this gave me a sense of it. But then it was also needing to learn how to like use that effectively in terms of actually like kind of regulate the emotion, understand it, and use that as motivation versus kind of just letting the anger fly.
What would have helped in my case, and we were talking about this after the episode we did with Liz, is, nobody ever really stopped and said like, Chris, this isn't okay in my family. I think people were just, let's just leave Chris alone. And that never really solved the problem. And so I don't know if this would be helpful, Felice, but for me, what would have been helpful is my family to approach me when I was calm, obviously like in a calm moment, and just say like, we don't know what's going on, because we didn't at the time, but we're going to find you some kind of help, even if it's just somebody to talk to, because the slamming, the breaking and stuff, that's not okay. And we love you and we care about you and we want you to get better, and we got to figure this out. But the turning to anger is just not okay. And it has to be dealt with. And I think that's why, Barbara Van Oppen at USC talks a lot about family contracting. It's like getting together with the people in the house and having that discussion in a calm moment and saying, okay, we're going to start handling situations different. What does everybody need? It's not going to be perfect, but we need to work on the escalation. And this is some things that we could do as a family to minimize that, because the anger, the breaking things, us screaming, us yelling, and, Chris, like what I was talking about earlier with, having a parent yell and then the other parent is yelling at the parent and then the kids are crying. And it's like, OCD is just chilling in the basement, laughing at all of us because we're just yelling and screaming and running around with our heads cut off, and nothing is getting solved. If anything, the OCD gets worse.
Yeah, it gets what it wants, right?
Yeah. Take over the family. What Nathaniel was saying about power, I never thought of it that way, but I do get it. It's, there was certain this like, why are you being disobedient? Why are you, or you're just going through a phase the same way, in terrible twos were no. Okay, this is just the terrible sevens. And this is what you're going through, and you're just trying to draw attention from the other things that we need to do as a family. So maybe there's a piece of me too that was like, I'm the dad, I can yell louder and I can tell you to do what you're only 7. So, you have to listen to what I say. And OCD is like, no, I don't. Right. Like Nathaniel was just saying, yeah, bring it on, keep yelling. This is great. This makes it worse. I get to control everyone now.
Yeah, and I think there's one of the things I always like to highlight for people is that like we see similar things with anger, like feelings of increased anger following trauma too, partially because it does serve somewhat of a protective factor, that fight or flight, right? Is it feels better to kind of be approaching something or feel that fight piece than feeling like you just want to run away because you have no clue what to do. And so there are elements of that that are kind of hardwired into us, into our sympathetic nervous system activation. And so, in some ways, knowing that it's there. The other thing they always highlight for people when like going through it, if you're going through OCD, is that sometimes that like when you're throwing stuff, or Chris, you mentioned breaking stuff, things like that, and sometimes that the goal underneath some of that sometimes can be that physical pain almost overrides the emotional pain for the moment and gives you a small reprieve. But we know it makes things worse. It doesn't last. So using like, distress tolerance skills, like holding ice is one I really like using. It's like just hold and squeeze ice cubes, and it starts to kind of hurt, like your hand goes numb, but it's not dangerous. It doesn't hurt you. And you can use it as a mindfulness exercise as a way to just kind of like get through that initial flash of anger and then kind of get to the emotion underneath. And so even using some small things that it's good for all of us as humans to know.
Absolutely. I wanted to bring on at 12:15 Petro Demetrio Kallis. I'm half Greek, so I can definitely tell it's a Greek name. I have OCD for 10 years, and I want to ask if you believe that it's better to see a psychiatrist or go to some clinic. So I'm going to ask you first, Nathaniel, from a clinical point, and then ask you, Chris, how you guys decided the level of care. How does someone determine I need to go to a psychiatrist, or I need to just see a therapist outpatient, or hey, I should go to a clinic that specializes in OCD treatment and see if there's some higher level of care like a partial hospital or residential? How is it best for people to navigate which kind of treatment they should approach when first seeking out care?
I've always kind of approached it in the majority of cases, and there's always times where this isn't true, where like a higher level of care is needed kind of faster. But I've always encouraged people to think about like the stepped care approach. And in terms of if you don't have an outpatient team, finding a therapist that does ERP and CBT and that can provide support, finding a psychiatrist that they collaborate with. If you have a clinic that has both in-house and they work as a team, that's a great option because you get kind of a wraparound team approach and they are all communicating. I think one of the reasons why it's important to try to find both a psychiatrist and a therapist prior to higher level of care is because even when you go into a higher level of care, there will come a time where you have to transition home. And that support and people that you trust and that you can kind of talk with before kind of transitioning out of a higher level of care about what you learned, what you're practicing, what you're working on, that they can help you with that transition. Because that's a very challenging transition. I think it's really important to have a team that you trust, even if it's difficult to get started on the ERP, but if they can do some of like the treatment readiness work with you, help you understand what you're struggling with, what treatment looks like, what are some of the challenges that may come up, what higher level of care may look like, so that you're ready for it. I think that's really important. And so I would recommend finding a therapist and a psychiatrist. The key is even if they're not in a clinic together, I think making sure that they're also in communication and letting them talk as a team so they can coordinate both the medication and the therapy is really important, and figure out what's the best fit for you or if a combination is the best fit for you.
And Chris, I know you alluded to it. Maybe you could expand on it with Petros's question. How did you guys decide that the medication, seeing a psychiatrist for medication was important? And then how did you kind of work with a therapist to determine how frequent you went? Did you go to a clinic? Did you go to individual therapists? Like how did you as a family plan and then eventually land on what you decided?
What Nathaniel was just saying with like step up care is I started to think like our first goal was like find somebody who can do the diagnosis, and that led us to, we actually had conversations with psychiatrists and psychologists, and it was like, okay, then it was okay, who's free? And we found that sometimes talking to the psychologist or the psychiatrist, gave us intros into the regular therapists, because it was almost like the recommendations. So that's kind of how it was like, let's get the diagnosis. Then we found the actual therapist that could do the day to day, or in our case, it was week to week, and it was really how we managed the level of care was what the therapist recommended. And, our daughter's first therapist recommended, okay, let's start with every week. We'll see how it goes. If we need to do twice a week, we'll do that. If we need to do, if things start getting better, we'll figure out, maybe we'll do, twice a month and then once a month. And then when it came to needing, thinking about medication and going to a psychiatrist, we asked for recommendations from that therapist, and she actually, knew somebody. So I think that was good, because then we knew if our therapist knew somebody who was also involved in OCD treatment, that they could communicate, and knowing that they could talk about, okay, here's the dosage, here's how it's working, and they would communicate periodically. So he would get, the psychiatrist would get updates from the therapist. That was really helpful. But we also knew as we were doing that, investigating other programs to go, okay, if this doesn't go well and this isn't working, what are the other things? So understanding, okay, at the time there's a place in Boston called McLean. There's a place, Rogers at the time, I think, might have only been in Tampa and in Wisconsin. So like, there's a place called Rogers. What are the intensive outpatient areas that we might need to go to if we needed something, more concentrated, or, a higher level of therapy? So we were kind of like working our way up and understanding if things didn't work, where we could escalate to.
Yeah, in my own care, I tried to do it without medication, and I wanted to do an intensive, but unfortunately, it was like a year waiting list at the time at all the intensives. And I did outpatient, even though I probably needed something much more consistent. So it was availability. But after about 6 months of trying the treatment, just doing so well, and then just kind of hitting a plateau, and then finally deciding, okay, I need to get medication. So I think, Petros, what I always say is I was scared to take medication, but meet with a psychiatrist that specializes in working with individuals with OCD, and bring your questions, because with OCD, we always have questions, but really just talk to them and get to a point that you feel comfortable enough that you walk out and you feel like you have somebody behind you as support. So,
Chris, sorry.
Yeah,
I just think in general, anybody, if you think whatever you think you want to, you need to see a therapist for it, it is important to kind of ask those questions. And in the same way, it is like, the stigma of how do I tell people I'm going through this outside of it? When you're walking into a therapist's office, or you have that first conversation, make sure, identify certain, if you can ask, like, these are what I'm feeling. How would you treat it? What are your credentials? Things like that, so that you understand if you're seeing the right person. I think sometimes, I understand why seeing the MD degree, or the doctor, initials before somebody's name makes you go, okay, I trust what they're doing. But you should have some questions, so you feel comfortable that, like, this person can help you, or this person, has helped people like you before. And therefore it gives you a little more confidence, even though one of the first things I learned in therapy was that, the therapist isn't going to just magically go like, okay, here's the thing that's going to get you, it's like their job is to listen and you help figure it out yourself. But it does help, you should also feel comfortable asking questions, more than just, what time can I come, and how long will we go, and how much it's going to cost.
Absolutely. And there's a really good place on the IOCDF website that lists different questions that you should ask a provider, and the answers that they should be giving to feel comfortable enough. So questions about ERP, or how much of their clientele are specifically individuals dealing with OCD. Shout out to Liam. Thank you, Josh, from Massachusetts, Spence from Kansas. Phyllis makes a good comment at 1218, finding a specialist for her son. She struggled with finding a clinician that worked with both OCD and BDD, because her son has both. So thank you, obviously, to IOCDF with a link of finding help. But what I wanted to turn this into a question, Nathaniel, I know you work with PTSD. I don't know if Vanessa had any co-occurring disorders, but how important is it to find somebody that can treat everything that you're dealing with? Or is it okay to see two different clinicians at the same time? One may be dealing with OCD and BDD, or trauma and OCD. Like, how does somebody navigate if they're dealing with more than just OCD, to find the right level of care? Should it be a one-stop shop? Should it be multiple people? What works best?
I think I'm going to answer your question with kind of sort of a non-answer, in that it really depends on each case, and kind of whether or not they're interacting, how they're interacting, but also on the providers that are available to you at the moment. I think it's a good question to ask if you're in treatment and you're having kind of co-occurring challenges, is to ask your therapist, like, what do they recommend? Because I've done both. I've done some where I've done integrative treatments, and we have some research on integrative treatments. A good example is like substance use and PTSD is well researched. So PTSD and panic, and then it's emerging in like PTSD and OCD. It's kind of an early literature that we're working on. But I think the key is that there isn't necessarily a right or a wrong. But the one thing that I would say to make sure of is that if you're working with more than one person, make sure that they're in communication, and that your team is connecting with each other and they know what each person is working on, so that there is a kind of cohesive plan. I think that's usually where it gets the most tricky, when you have two separate therapists that don't know each other exist, or work on two kind of separate things, or aren't talking. And if they haven't connected, ask them to. And that's 100% within your right to ask them and say, like, I'd like you all to coordinate. Could we have a team meeting where we all kind of just touch base for a minute so you can let me know, like, what is the game plan for this? And so I think that, it's whatever kind of works best. If they are really separate and not kind of like connected in that sense, then having two separate therapists can work really well as long as they're kind of both monitoring what's going on. There are times where like it's really overlapping. This sometimes happens with OCD and BDD because they are both OC spectrum diagnoses, where you might want to have someone that has like experience with both. And it's a little bit easier to find that at times than for some of the other kind of comorbid conditions. But I wouldn't say one is off the bat is better than the other without actually, like, it's more of an individual case-based piece and what's available, but both can be highly effective. The key is making sure everyone's in communication.
That's what I was going to add is like, for me, my therapist with OCD said, look, I don't treat BDD, and referred me to someone and they collaborated. Whereas like I treat both and I feel comfortable. But if somebody was to come in with like an eating disorder and OCD, obviously refer out. So I think what's important is to ask your clinician, do they feel comfortable treating what what you're dealing with outside of OCD? And if not, is there somebody they recommend? I saw you shake your head no to Vanessa having co-occurring disorders. So I'm going to bring the next question to you, Chris. So Ashwin at 1228 says, how do you deal with the fear of starting a medication when you've already started feeling better and feel that medication might worsen it? So with sometimes with medications, people maybe at the very beginning start to see like, side effects or see their symptoms rise a little bit. But for most people it plateaus and then the medication actually really helps. Did you see any of that with Vanessa? And how did you guys navigate that?
I had a very mistaken belief that like, the SSRI was almost like, it'd be as effective as a Tylenol in the sense that like, okay, 20 minutes or half hour, if you take it, it starts to work and you start to feel better. And so my initial thought was like, okay, a day or two and things will really improve. And then I don't know where I found this, or maybe it was just something in research, but, I just read that, it can take 6 to 8 weeks from full dosage to really start getting effective. So that really allowed me to be a little more patient and understand that it wasn't going to be immediate. And yet I will say there was probably within the first 2 weeks, we did notice something, but to your point, I think there was a plateau, and we started Vanessa really, really small. Like I remember like buying the first time we bought a pill cutter and like cutting the pill into quarters and like going to a quarter and then a half. And then, so it really took her a long time to get up to that full dosage. So yeah, it was a slow, gradual process. And whenever I see comments on a lot of the Facebook groups that I'm a part of that talk about medication, I always want to make sure that people understand that it differs based on the person, but it also, expect that it could take a long time from full dosage. And that I hope helps people understand the patients, and eventually it will work. But again, it's like trust in the process is another close thing you have to do. Plus you're just monitoring your child or yourself. Like, how is this affecting me? And how, which is, I think, maybe the reason why there is that like slow, gradual, like you'll start small. You're not going to take the full dosage at first time you get it.
Yeah. And I'll just add to that too. I mean, I was weary because I took medication for a little different reason, which, than the question, it was because I did plateau. I think if you're working with someone and you're doing well, I would say if you're doing well, what would be the reason that, you add medication? You might not need to add it, but if you do decide to add it, there may be some side effects and stuff in the beginning, but I know for me, like taking medication, it made my thoughts less frequent. It made the thoughts less intense. It was so much easier to let thoughts go. And I found myself motivated to do the treatment. So it's really, medication can be extremely helpful. And there's also a lot of people that get better without it. So that's why I always think really finding a psychiatrist who specializes in working with OCD and related disorders and having that conversation so you guys can discuss what would be the importance of adding the medication. I rarely hear, though, that somebody's doing really well, they get on medication, it just bombs their treatment. So I don't think that should be a concern. But once again, I would definitely talk to the psychiatrist. I'm going to bring you back in, Nathaniel. We have a question from Gandek at 1235. Is using the insight experience of knowing that OCD has lied to you so much in the past a compulsion when intrusive thoughts pop up, or is it better to not remind yourself at all mentally? So, when somebody is recognized like, hey, OCD consistently lies. I remember I did a talk, or I didn't do a talk with Chris, but Chris and I were speaking at the same conference. And I remember that statement. You're like, OCD lies, it always lies. And I think it was just so clean and clear and brilliantly said. But how can people use that knowledge that OCD always lies to them in a way that's effective for treatment that doesn't turn into a compulsion?
That's a really, really great question, because I think that's one of the trickiest parts about OCD is that a lot of times, OCD can kind of turn almost anything into a ritual, given enough time. But so I think it really boils down to how you use the statement, like and how you use that insight. So if in the moment you're able to say like, all right, I know OCD lies to me, this is an OCD thought, so I'm going to continue moving forward with blank, and then take that step and functionally move forward, then I think that's a great way to motivate yourself, a great motivator, a great reminder. The thing to watch out for is that if over time you notice that you're having to say that over and over and over again, and are never quite getting to like taking that step to do the next functional behavior, or if you're saying, all right, I just have to convince myself enough that OCD is lying and that this is just OCD in order to do the next step. And in that case, you're kind of trying to like, it's moved into like getting rid of the uncertainty, right? You're attempting to rationalize it or do mental rituals to try to convince yourself like well enough, if you will, or the right way that you can move forward. Versus if you're saying, all right, OCD lies, I recognize this is an OCD thought, so I'm not going to pay attention to it. I'm going to continue doing with what I was doing. And then you're able to take that functional step fluidly forward. Then that's a good indication that you're using it as a good motivator and kind of like reminder, if you will. So unfortunately, like the answer is kind of in the subtlety and the details of the how. Like, how are you using it? And what's the outcome? I hope that helps a little bit. It's a little tricky, but
no, I agree. I think, you have certain things that you learn through the treatment. There's data you collect. And by doing the exposure therapy, a lot of times my kid clients will call them like experiments. And, they'll say, look, I've done 15 different experiments with you since we started. And each time what OCD tells me is going to happen doesn't happen. So then when we go to do a new exposure, they're like, I'm feeling confident because I've learned that OCD lies. And so I'm willing to lean into this because I know that this is probably another lie from OCD. That's totally fine. However, if somebody's walking around, let's say they have pedophilia thoughts around kids and they're taking their nephew to the park and the whole time they're like, OCD lies, OCD lies, OCD lies, OCD lies. OCD. I mean, if you're doing that the whole entire time you're there, then it's become a compulsion. Like you're specifically using it. And I always say it's about motive. If the motive of saying that to yourself is to remind you that you got this, let's go do ERP, let's kick some OCD butt. Awesome. If you're doing it because you're trying to calm yourself down and kind of check out from the anxiety, then that's when it's a white flag, or red flag, not white. Chris, I wanted to bring you back in. First of all, Josh made a really good comment. I love the support everybody's giving each other in the chat about how anger is so much easier to externalize. Felice, and I thought this would be a good question for you because dealing with teenagers, Felice asked another question at 12:30 about, when her husband gets really angry and then apologizes, like, how does she keep accepting those apologies? Because the anger hurts. So obviously having a preteen and then a teen with OCD, because when I was a teen with OCD, I was horrific to my family. How did you be okay when Vanessa had like a really bad day and snapped at you guys? You're the worst parents ever. How did you accept those apologies without taking it so personal? Because I think the individual that doesn't have it, it feels like a personal attack.
Well, one of the first things we also realized, it was like, okay, she needs help. And other people have heard me say this, and then we realized we needed help, because the more we started to learn about OCD therapy and treatment and, exposures and certain things that we might need to do, it was like, well, we need to talk to other people about this, not just ourselves, and not just each other, and rely on each other to be each other's therapist or, each other's, ear to listen to. And so I find it was really important for us at the time. We had to start our own parent group, but we did find like a Yahoo group, which was like an email, blast that would go out every day. People ask questions. Now it's like, I highly recommend people look for closed Facebook groups that they can talk to, or somebody was mentioning a WhatsApp group, any group you can find that will allow you to that people have identified with lived experience, whether you're a parent, whether you're somebody living with it, who you can kind of just feel somewhat sense of community, that helps, because then you can, in some ways, for us at least as parents, it was like, let's see what other people have gone through. How do they deal with, what do they deal with, anger and rage? It's so big. Yeah, there were a lot of times where my wife, almost like during the really crisis periods, it's like we were less married and we were more teammates than we were like, husband and wife. It was like, if I had a really bad day, it was like, you have to deal with this. I can't, time out. I can't, you got to deal with this. And we really learned to communicate in a very different way. And that took a lot of work. It was, it stressed out everybody. So, one of the ways that we were able to deal with anger and all the things we just didn't understand and weren't prepared for that OCD would throw our way was by, finding others who are going through similar issues and kind of getting comfort and advice and, knowledge from them.
Well said. Featurist at 1249 says, hello from Ontario. Our 19-year-old son has developed OCD so bad it's caused him severe gait walk. Also can take hours to do simple tasks like stairs. Featurist, please go to iocdf.org/find-help. So that's a great place to go, where they list all the different providers in your area. One thing I always say when people reach out to me, thank you, Chelsea. When people reach out to me and tell me about, they see me advocating, they tell me about their kid dealing with it. What I always say is find help. Really use your resources, insurance, low cost support groups, clinicians that do super bills, anything that you can find to find help. Because if you can tackle it now before it becomes extremely severe, it's so much easier to deal with. My OCD, I dealt with it for like a decade before I got help, and it just makes it harder. What I'd like to do, gentlemen, in the last kind of 8 minutes or so, Thanksgiving's coming up. And one of the things that I hear from a lot of people, I run weekly support groups. And what I hear from a lot of people is that, they're not as excited about Thanksgiving as other people, because maybe they have a family member that brings on intrusive sexual images and thoughts, or they take some hours to get out of the house and they show up late all the time, or they're stressed about, the drive because they have hit and run OCD. So, I'm going to start with you, Nathaniel, and then go to you, Chris. What are some things that people can do with OCD and families to kind of prep for tomorrow, Thanksgiving? Or, if somebody on here doesn't celebrate Thanksgiving, I don't even know if Thanksgiving is in all countries, but any holiday season that's coming up, what are some things that people could do, either from lived experience or clinical experience, to kind of mentally prepare for that so that they don't let the OCD sort of go awry?
I think one thing just kind of universally that tends to happen at big events, if you will, or family gatherings or holidays, that I always encourage people to keep an eye out for is, what are the expectations that you're going into it with? Because I think one of the things, and why I think because anecdotally, you tend to see big, blow ups and fights at holidays, right? And people getting in arguments at a certain point. Sometimes we always talk about that as the risk of the holidays, but it doesn't happen for everybody. But I do think in many of those cases, whether OCD's there or not, one of the biggest challenges is we tend to go into these bigger events with certain expectations about what we think it should be, the way it should experience it. Is it good enough or not? Is it the way that we kind of idealize what's going to happen? And when that happens, it leads to a lot of stress, a lot of extra anxiety, a lot of extra frustration when things don't pan out that way, in addition to the anxiety that may come from the OCD or whatever else is going on. So I think being kind of cognizant of those expectations and kind of checking them ahead of time and saying all right, what are my expectations that I maybe haven't acknowledged for myself? What's potentially more realistic and going to happen? And how can I kind of acknowledge that that's there, prepare for it, but also kind of stay in the moment versus trying to compare this to this ideal, right? It's find those little moments of happiness that you can enjoy versus putting the pressure on everything about this has to be ideal. Find those individual conversations, those small moments, the kind of getting to see or hug someone that you haven't seen in a long time, and kind of allow that moment to be there. But so I'd say kind of monitoring your expectations can be a really, really important thing to do.
Yeah, well said. How about for you, Chris? With the holidays and any stress and family maybe not understanding the disorder, extended family, how did your family navigate when Vanessa was struggling around the holidays?
Couple different, one thing that we felt was helpful too is we would prepare for her for what, was as much as we could for what was going to happen. So, these are the people who are going to be there. Maybe, if if somebody maybe she hadn't seen in a while, this is where you might know somebody. This is the house we're going to, like, remind her of, and, you know, this is what we're going to do when we get there. And then establish kind of like, if you are having a thought or you have a fear or worry, like, here's how to bring it up to us if she didn't want to make it public. So sometimes it would like be a signal she would make, or so that we knew, okay, she needs a little time out or something. So it was like preparing her. Also for us as a family, like what we were prepared to talk about and what not. And took a while to understand that if this is the first time talking about OCD or any, you know, mental health issue with somebody, they're going to have a lot of questions, but you don't necessarily like understand what you're comfortable talking about right away. And you don't have to lay everything on. Maybe just see how they feel and understand that it'll probably be a bigger conversation later on. And then lastly, ourselves, I mean, there's always just the management of how do you deal with stress. For me, it always seems to come down to like, you know, is the thing I'm baking ready, and is it going to spill or something when I'm transporting it? And then, you know, what time do we have to leave? So I am always the time police, you know, like we got to leave at 2:30 because there's going to be traffic. And then it's trying to like, always, and I don't always do this, but like, you know, prepare how I'm delivering that information on that day, whether it's Thanksgiving or New Year's or, you know, going to July 4th, you know, making sure I'm trying to deal with more of a calm way. And it's okay if we leave 5 or 6 minutes late, that's okay. Roll with it a little bit. Eventually you'll get there. You know, which I know is sometimes funny. My wife one time was like, you know, we're going to get there for 10 minutes. Like, it's okay. You know, okay. Yeah, you're absolutely right. We don't have to get there right at 2:30 when everybody said they were going to be there. So it's being a little more flexible.
Yeah, just let me know Thanksgiving's only in America. So I'm going to make my advice for any family gathering, holidays or not. I think the two big things that I would add is just one was, you know, my family started saying, and it was really powerful, is like, we are not going to wait till you get here anymore to start dinner because we're tired of sitting here for hours and we're accommodating. So dinner is at 2. If you show up at 4 or 5, your food's going to be cold. You got to reheat it. And it encouraged me to use my tools and get out. And then I think second, just my family my mom talking to my family, like, he's going to be doing some things. Please leave him alone. Like, let him work through it himself, because it doesn't help your nasty, rude comments. So those good things can help. Finally, I want to give both of you guys final thoughts. I know we talked about a lot of different topics. There was a lot of great conversations, features. I'm glad that helps. Please look into treatment and find care for your son. There's a great community here at the IOCDF, so anything we can do to support, please let us know. But any final thoughts? I'll start with you, Nathaniel, on anything we talked about or anything that you would like to let people know watching, just kind of like a final thought you want to leave them with for sure.
Sure. I mean, I first just want to say thank you to both of you for having me join you all. It was a wonderful conversation. And I think for those
normally we only invite people who have the name Chris. We try to keep it a Chris exclusive club, but Chris and I talked to the board, and the Chris's came back and said this once we can allow you on. So,
well, thank you. I appreciate that. It means I don't have to go through all the name change paperwork for Massachusetts. So I appreciate that. But I mean, I would say just for anyone who's in attendance, you know, I'm really happy everyone joined. And I really just wanted to reiterate, Chris, what you had mentioned in terms of that everybody's trajectory and recovery is a little bit different. And we have tons of data to back that up. And so, you know, even if things feel like they're not progressing, maybe how you see your peers or friends or other stories you've read, keep at it. Like, these are life skills that you're learning through treatment for OCD, not just OCD only skills. And they're good life skills that will help you in the long run, but they take time to practice. And, you know, I hope that for each of you, kind of give yourself a little bit of that self-compassion that, all right, it's an ongoing process. As long as I'm continuing to try, then you're continuing to progress. And so we wish you the best and kind of allow your path to be your own.
Well said. How about you, Chris? Any final thoughts?
Thanks, IOCDF, for having us on today. Thanks, Chris, for the invite, and Chelsea behind the scenes for keeping things going. I just I'm hopeful that so much progress has been made in the last decade on speaking out and destigmatizing all mental health issues, making it more of the conversation. And I see that as a good sign moving forward, so that future generations might not have the same obstacles that we're discussing today. So I'm, you know, I'm hopeful that that is going to lead to more people seeking help, more people finding help faster, more therapists being available for help, and all those good signs, and bigger communities that are expanding to offer help. I think anybody that's going through trouble now, or maybe might be having a hard time, one thing to understand is that at some point you will be at a chance where you can help somebody else. And that to me was really helpful, understanding like where we are now, that like, oh, now we're at a point now where we can help others and we can be the ones providing information, even if things weren't 100% great. And that was, that is something that, you can strive for and look to do and maybe down the road.
Well said. Don't go anywhere, gentlemen. I want to say a proper goodbye, but my final thoughts, I wanted to say hi to Pauline from Liverpool, UK. And that's basically my statement. I mean, we had people from Greece today. My family's from there, just seeing the community. I love this, having people from all over the globe. The virtual component has brought people all together, and just knowing that the IOCD is here for everyone. So thank you to everyone that asked questions in the comments, supported each other. We absolutely love that. A couple final things. Don't forget that registration is open for the online OCD camp. This is created especially for youth between ages 6 to 17. And the camp will feature 2 days of interactive sessions for parents, guardians, and for 3 age groups. In addition, the program will include sessions for parents and guardians and opportunities for fun and socialization with other families. Learn more and register at iocdf.org/OCD camp. Chris, you've been to those before, right?
Yeah, I was emceed the last 2 with Susan, so that's been fun, and my family spoke at the last one, so really good chance to, again, meet people, learn a lot. Your kids can do their own thing and be on their own Zooms, and you can be on, with them or at your own session. So you're staying at home, but it's a great place to learn, and it'll be winter time here in the US, so not a bad weekend to kind of like cozy up with some hot chocolate and learn about how to put OCD back in its place.
Absolutely. Really, really good place to go. So make sure to join us. Join the Peace of Mind virtual community at iocdf.org/peace of mind. You can view live stream schedules. We love for you to submit topics when we're backstage kind of brainstorming what to bring you. We always listen to your comments, and you can also ask future questions. Don't forget Giving Tuesday live stream, where it's going to be myself and the other national lead advocates this upcoming Tuesday, November 30th at 12 p.m. Eastern. So that's going to be a good way to give back to and bring up education and support and resources for the IOCDF. Don't forget to like and subscribe on whatever platform you are watching, and make sure to visit iocdf.org for everything. So thank you so much to Chris and to Nathaniel. Thank you so much for coming by. Carol, have a great Thanksgiving. Everybody have a good holiday season.
Happy Thanksgiving.
And it was good to have everybody on. Thank you so much.
Thanks
Take
for
care,
joining us.
everybody.